The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flight Bridge Ed in their entirety. This is the Flight Bridge Ed podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hello, everyone, and welcome back to the Flight Bridge Ed MDcast. My name's Mike Lauria. I'm an emergency medicine, EMS, and critical care physician with a particular interest and focus in critical care transport and retrieval. Today, we are back with our series, Every Breath They Take, on advanced management of respiratory failure in the transport environment. And I am joined today, once again, by the illustrious Dr. Brittney Bernardoni. She is a emergency medicine and critical care physician who also works as a flight physician. So she is also a retrievalist and works up at the amazing Intergalactic University of Wisconsin in Madison. So we're a pleasure to have you back, Brittney. Welcome back.
Hey, all. Thanks. Glad to be here.
We've had previous conversations, especially Brittney was awesome, and we joined us with our group on ARDS management, and we talked a lot about some of the fundamental evidence and ARDS management techniques, but we wanted to sort of take a step back because probably the most important part, and I think what we see regularly is a lot of the time in the vast majority of patients in mild to moderate ARDS, really good basic ventilation strategies and lung protective ventilation can go a long way. It's also the foundation of ARDS management with probably some of the best evidence. But how we set up the ventilator and what I like to call the jiu-jitsu of ventilator adjustments, I think is really important. So we're going to go over that today. Now, I call it jiu-jitsu because it is this slow, controlled grappling and essentially making small titrations to optimize some of these parameters. So when I think about it, not that I'm fighting with the ventilator, but that we're making these adjustments to sort of optimize things and help out our patients. So without further ado, let's start out with a very important topic and a question that's come up a number of times, Brittney. I've heard flight crews and people in the emergency departments, whatever, we'll get them going as long as their sats are fine and as long as their, pH isn't 6.5, like they're fine. You guys can work out the ventilator stuff anyway, plateau pressure, whatever. That's like for the ICU. That's in days and months to come. But is early management in the ED and in transport actually helpful? Should we be doing that? Why? Why do we care?
Yeah, so this is one of my favorite topics, right? Because I hear this from my team all the time. So there was actually an awesome trial out of WashU that came out a few years ago, the Love ED trial. Basically what they did is any patient who was intubated in their emergency department with ARDS, they had a RT-based protocol just doing basic lung protective ventilation. So nothing fancy, just doing 6 cc per kilo tidal volume, doing a PEEP per the ARDS table and weaning their FiO2. They found a number needed to treat of 7 for a mortality benefit, which is insane, right? Like it's hard to find any mortality benefit in ICU study. So what we do in the ED absolutely matters for patient mortality. And that's not even including, ventilator-free days or hospital days. There was also a more recent study that has come out looking at what we do in transport as compared to what they do in the hospital. And it found that the settings that we choose in the transport environment are typically continued in the hospital for anywhere between the first 8 to 12 hours. So honestly, what you're doing and what you're setting up is likely to be what the patient's going to be on at least for a chunk of time when they get to the ICU or the ED. And we know ICU and ED care matters. So our care matters.
I cannot agree enough. And this is exactly what I try to emphasize to crews. I try and emphasize it to small critical access hospitals when we do training and we talk to them, or they ask questions or ask for feedback. I'm telling them it does matter. Early care matters. Just like in trauma, like the first person to put on a dressing, an early initial management of hemorrhage is super important. Perhaps the most important thing for some people is throwing on a tourniquet early and stopping hemorrhage. I think it would be interesting to see moving forward early versus later management and how much it really matters by the hour even just like ED versus ICU or transport, but like each hourly, for every hour that goes by, they're not being managed correctly early on. I bet you there's a signal there that the earlier, the better is in fact true. And this study at least suggests that the location and initial management is super, super important. And I think our practical experiences in the ICU, working in the ICU and the ED are probably the same, right? Patient comes in overnight, a very well-meaning resident admits them, and you come in the morning, and the changes from what the crew reported as the vent settings are essentially the same. They've translated them over. So whether they're good or bad, they've been that way for like 6, 8, 12 hours, and that may make a big difference as well. So it really does matter. I cannot agree with you more.
Absolutely. Have confidence that there is a solid chance that you as the transport crew know more than the resident picking up the patient at the tertiary care hospital.
Yeah. So we've kind of established that early care probably matters, and what the transport team does to the ventilator is in fact important. Just a quick review in the overall scheme of things, right? Remember that the very best data that we have suggests that low tidal volumes are probably important. Lower tidal volumes generate lower transpulmonary pressures and are probably doing less ventilator-induced lung injury. So keep them at 6 per kilo. Plateau pressure, making sure their static compliance, or based upon their compliance, the static transpulmonary pressures, or at least a surrogate of that with the plateau pressure less than 30 is there. And then early proning, really good data for that. And again, and I'll refer you guys to the other podcast that we did, looking at some of those other potentially helpful treatments, which with some data, but still somewhat controversial. Early paralysis, looking at driving pressures, steroids, VV ECMO, et cetera, et cetera. So check out the other podcast for that. But today we are going to focus on the fundamental ventilator jiu-jitsu, right? So let's talk about initial ventilator settings. You get to the bedside, and let's say they just intubated this patient at the outside hospital for ARDS secondary to COVID pneumonia or influenza pneumonia. Let me ask you this. The mode we choose, does it matter between volume control and pressure control? The ARMA trial was done in volume control, right?
You are totally right. And this is a question they have asked over and over, right? There are hardcore people who say pressure control is the way, and hardcore people who say volume control is the way. Every time they've tried to study these head to head in all the trials, there is no difference. What it comes down to is pick whichever mode you are most comfortable with and you understand and can titrate the best, and just go with it. There is no magic in pressure control versus volume control. For our team and most pre-hospital teams that I've worked with, most people are most comfortable using volume control. So the majority of this lecture is going to touch on a volume control mode, but all the principles apply and can be translated over to a pressure control mode as well.
I think that it's also really important. I'm just going to touch on this really quick, and you can comment on it, but we'll save the full discussion actually for another episode, because it really does deserve its own episode. Is we are going to talk and focus on volume control and some of the settings and how we titrate them. But the Hamilton, the most commonly used at this point and growing transport ventilator, especially amongst hospital-based crews, is actually unable to do a true volume control mode. Brittney, would you like to just talk briefly about what mode that is that the Hamilton actually does, and why that's important to at least be aware of it? And then we'll do our whole other episode on this.
So in the Hamilton, depending on which nomenclature system you use, this is either CMV or APV CMV. Either way, it's the mode where you set your tidal volume, right? However, what the vent is actually doing is when you set that tidal volume, the vent is deciding what change in pressure it needs to achieve that tidal volume for the patient. So what the vent is actually doing is it's delivering a change in pressure. So it is a pressure control mode of ventilation, but the pressure that's given to the patient changes over time depending on what the patient's doing with the ventilator to try and achieve the tidal volume you set. So basically, it is the same tidal volume every breath, but the pressure that the vent is using to achieve that tidal volume changes.
And again, the nomenclature for this is different on different ventilators, but we'll commonly refer to this mode of ventilation in the ICU as pressure regulated volume control. So the machine is regulating the pressure or changing the pressure delivered to the patient to target that volume that you say, hey, make sure they get at least this much volume. So that's important to know. And again, we'll go over some of the important logistics as it relates to transport and transferring patients over to our ventilator from another hospital's ventilator. But again, let's dial it back. We'll pull it back a little bit and get to the fundamentals of, let's say we did have a true assist control volume control mode. What volume should be going with and why? What's the basis for this whole 6 cc's per kilo thing, Brittney?
Yeah, so this goes back like 25 years now, which is crazy, to the initial ARMA trial in 2000. And then more recently, there was another trial in 2012, basically looking at lung protective ventilation. And these are the trials that really gave us that 6 cc per kilo tidal volume, and potentially needing to go as low as 4 cc's per kilo, with the idea that that lower tidal volume will cause lower pressure because you're putting less volume in a small space, and that's pretty important. The one key caveat to this, and the thing that I always talk about with my team, is the body weight that you're using to decide what tidal volume is their ideal body weight based on their height, right? My typical patient in Wisconsin, a Wisconsin unit is 100 kilos, and 100 kilos is not most people's ideal body weight. So making sure you know what their height is so you know what you're going for.
Nice. I think regionally we've all come up with colorful terminology to describe the, shall we say, growing body habitus and how it does not necessarily relate to their height, skeletal structure, or lung size. So nice. One Wisconsin
Correct.
unit. I love it. I love it. Okay. So now we've set the initial tidal volume. Great. 6 cc's per kilo based on ideal body weight. Where do you generally, how do you conceptualize or think about setting your initial rate?
So for most patients, what I want to do for their rate is think about what is the chance of them having air trapping or breath stacking? What is the chance that that volume I'm putting in their lungs isn't going to be able to get all the way out? So if there's someone that has a history of COPD or reactive airway disease, they've got those, tight bronchioles and it's going to be hard for the air to get out, or a patient who already has a little bit of wheezing, I'm going to typically place them on a little bit lower rate, with the idea being they need more time to get that air that I'm putting into their lungs out. In patients who I'm not worried about that, I tend to do a little bit of a higher rate, somewhere between 16 to 18 breaths a minute. I don't go nearly as high as I do in my metabolic acidosis patients. And the reason being, if you kind of think about this like you would an aortic dissection, it's not just how hard you hit the lungs or how much pressure you're putting in, but it's how many times a minute you do that, right? So for dissections, we're trying to decrease both the heart rate and the blood pressure. So for patients who have ARDS, we know for sure decreasing the pressure in the lungs helps. And there's some new evidence that suggests decreasing the respiratory rate. So decreasing how many times you're hitting that lung probably is important too.
And are you by chance alluding to some of the new literature on mechanical power and rate?
Oh yeah.
Nice. So let's touch on that toward the end of the episode, because this is something that I just love thinking about and maybe sort of helpful, I think, as it relates to lung protection. But let's talk about one important thing, which is, as you mentioned, the amount of times that you jam that air into their lung is important. And we're realizing more and more that may be part of the equation, literally and figuratively, may be part of the equation that causes ventilator-induced lung injury. So in the ARMA trial, and I think many of our transport professionals are aware of this, we talk about permissive hypercapnia. So they don't necessarily have to have a PaCO2 of 35 to 45 or a pH of 7.35 to 7.45. So let's talk about that. What's your lower limit? What's your cutoff of where you won't allow them to be more hypercapnic or acidotic? And perhaps more importantly, who would you say, I don't really want to let this patient become hypercapnic, permissive hypercapnia? hypercapnia may not be good for them.
So one thing that's a little challenging about ARDS is, unlike in trauma, where permissive hypotension generally has a pretty clear definition that most people have agreed on, permissive hypercapnia really doesn't, to be honest with you. The majority of studies looking at this care more about a pH than a PCO2. So most people will generally agree that as long as their pH is greater than about 7.2, you should be okay. And you can just let that PCO2 kind of ride up as long as you're maintaining that pH. Again, there's no great evidence for this. This is just kind of a clinical gestalt expert consensus kind of recommendation. And as you alluded to, most people tolerate this really well. As long as their pH is greater than 7.2, that PCO2 doesn't seem to hurt them. But there's a few patient populations that this really probably isn't appropriate for. One of those would be pregnant patients, right? Because you need that CO2 gradient to ensure that the fetus has appropriate ventilation. So those would be patients where you'd want to be targeting a lower PCO2. Another one is your brain injured patients. We know kind of blood flow to the brain. One of the big things that regulates that is your CO2. So having a lot of CO2 will dilate those blood vessels in your brain and can potentially cause increased pressure and or increased injury and edema in the brain if you're brain injured. So those are other patients where you really don't want to let it ride super high. Patients with poor cardiac function, and especially poor right-sided function, you get a little nervous about a lower pH just because the myocardium doesn't squeeze as well at a lower pH. In patients that have a sick right side of the heart, a higher PCO2 will increase the pressure the right heart is pumping against. So those are other groups where you want to be cautious. And then anyone who's had a significant overdose, aspirin, TCAs, sodium channel blockers, you generally want them to have a higher pH just to help kind of metabolize and get those toxins out.
And I would reemphasize to everybody, I really love how Brittney addresses this, because often we've sort of traditionally in education and critical care transport, we divide it up into obstructive strategy or basically for obstruction or lung protection, right? They either have COPD and asthma, or they have ARDS or some sort of other pathology where we're trying to protect their lungs. I think it's important to remember, and I like the way that Brittney kind of considers this, because in terms of the rate, because we have plenty of patients that have COPD and asthma, and then they get a big honking lobar pneumonia, and then they develop ARDS. So they have intrinsic obstructive pathology. And on top of that, they have this heterogeneous ARDS and whatnot. So sometimes you should consider it, and you should, really consider how you're doing it and look at it and evaluate if what you're doing is working. Sometimes maybe you need to sneak a little bit lower on the rate and address their obstruction. Sometimes they are really have sick, socked in ARDS, non-compliant lungs, and the obstruction is really much less of an issue, especially if their COPD is, or their asthma is mild and well controlled at baseline. So awesome. Very important thought. So this scenario comes up all the time. So we put in a rate of, let's say 18, 20. And the lovely thing about some of these modes, assist control, either pressure control or volume control, or PRVC, is that the patient can trigger their own breaths. So what do we do, or why should we be concerned if we program in 22 breaths, let's say, and now our patient is actually over breathing by 4-6 breaths, breathing 26, 28 times a minute? And when, Brittney, do you consider actually increasing the rate or adjusting it to meet the patient demand?
In general, if they're 1 to 2-ish triggered breaths above my set rate, I'm that's fine. Some of the newer evidence is starting to say if they're breathing quite a bit over my set rate and they're taking, 4, 6, 8 breaths a minute over, there's a chance that the patient is doing something called self-induced lung injury, or SILI, which is just fun to say. The idea being that their respiratory drive is just so much that they are ignoring your attempts to put them on lung protective ventilation and limit the amount of times and the amount of pressure you're giving their lungs, and they're actually causing more damage to their lungs on their own above and beyond any damage the ventilator could be causing. So I really don't like them going more than 1 to 2 breaths above my set rate, especially early in their disease course at the point when we're usually picking them up for transport.
Yeah, absolutely. And this was, I think reading the literature, especially on the self-induced injury, was fascinating because really when you think about it, and some brilliant authors have done some really interesting work on this to show that if you think about it, like the force of your chest expanding and your diaphragm going down, triggering the ventilator. So that force plus the additive forces of the pressure from the ventilator combine to potentially make things worse. Very interesting hypothetically, and some observational data that's kind of concerning in this sense. But more and more, I agree with you. I'll I have a threshold in my mind of like 2 to 4 breaths per minute consistently. After by the time we're loading in the aircraft, essentially, I'll be adjusting it, either going up on their sedation or trying to adjust some other parameters to make them more comfortable and pull less on the ventilator. Awesome. So now let's talk about, we talked about tidal volume. We talked about rate. Let's talk about PEEP. Oh my goodness, one of my favorite topics. So where do you start with your PEEP? Some places just start at like 5 or 8, somewhat arbitrarily. How do you decide, and what do you usually set your initial PEEP at?
Awesome. So I would say in this day and age, I almost never, whether they have ARDS or not, will have a PEEP less than 8. And again, that's kind of going back to the idea that many of our patients have a pretty large body habitus, and that PEEP isn't just kind of holding the lungs open at end expiration, but that PEEP is also the pressure of holding their big belly and holding their big chest wall and meat on top of that chest wall off of their lungs and preventing it from collapsing. So there's actually a little bit of newer evidence suggesting 8 is the new 5 and 8 is the new minimum PEEP for many folks. But specifically when it comes to ARDS, how do I pick this? The best studied evidence we have is that old school ARDS-net PEEP table, right? So how you're supposed to use that, how that works, is you kind of pick your initial PEEP, you wean your FiO2 until you get to a SAT of like 92 to 95, and then you look on that table and say, let's say, all right, my FiO2 is 70% to achieve this SAT. And I look at my PEEP table and I say, okay, for a 70% FiO2, my PEEP should be either 12 to 14 or 16 to 18. And I say either. That's because there are 2 ARDS-net PEEP tables. There is the lower PEEP table and the higher PEEP table. And they've looked at this, right? And they've tried to show, hey, is higher PEEP better than lower PEEP? Do we know? And there's really not clear data that higher versus lower PEEP is better. So my general rule of thumb, if they are a really obese patient and they're going to need a little extra PEEP to help keep kind of the chest wall and the belly from squishing the lungs, I tend to favor using that higher PEEP table with the idea that they might need more PEEP. Otherwise, that lower PEEP table is very reasonable. And this is just what I'm doing to set my initial PEEP. We're going to, in a little bit, I think, go into the jiu-jitsu of picking an optimal PEEP, which is a whole nother discussion. But just kind of a good basic starting point, your ARDS-net PEEP table is going to be the best evidence-based way to go.
Let's talk about one last setting, which I think we take for granted sometimes, and we're potentially a little too liberal with the FiO2 dial. So before we get into the jiu-jitsu and how we're going to make some of these nuanced changes, let's talk about the FiO2 and why, for a number of reasons, it's probably not a really good idea to have it consistently pegged at 100.
Yeah, this is another topic very near and dear to my heart that I think is unfortunately under-recognized. So way back, all the initial ARDS-net data showed that an FiO2 more than 60% damages your lungs. You're getting oxygen-free radical damage. It's making your ARDS in your lung worse. There's some other evidence that having an FiO2 that's too high actually causes atelectasis. And above and beyond that, there's evidence that people who have ischemic organs like post-STEMI, post-stroke, just general poor perfusion, having a higher FiO2 may damage that tissue even worse. So it might make your stroke worse. It might make your STEMI worse. So more and more, I think we're recognizing that high oxygen is really a problem for patients. So your classic ARDS-net goal is to have an FiO2 less than or equal to 60% to try not to damage that lung tissue more. My one big beef with this is unfortunately one of our gamut metrics is if you drop your SAT less than 90%, and the standard SAT goal for ARDS patients is 88%. So if you're following kind of our ARDS basic management, targeting a SAT of 88%, you're going to fail your gamut metric. And we as a program have decided we're okay with that. We're going to do what's right for our patient. And if we fail a metric, that's okay. But I know that's a barrier for some crews and some groups not wanting to drop that SAT more than 90%.
Yeah, and I think that continues to be an ongoing problem. And in perhaps groups or organizations where the medical director may not necessarily be aware of this literature, I've heard anecdotally from various crews, it's like, I would love to be a little more conservative on the lung protective side, but that goes to QA if I purposely keep them at 88% or something like that. And so perhaps I think we still have some work to do on that front to say, hey, if we really want to protect their lungs and do the best as far as the evidence is concerned, under certain situations, if a patient's diagnosed with ARDS, totally reasonable to let their not shoot for a SAT of like 98% under those circumstances. So awesome, I agree. And I think the other thing that was really changed my mind on this, I'd be like, okay, in STEMIs and some of these other things, FiO2 and whatnot being that high, probably not good. But in ARDS, like, what harm can it be doing if their SATs or their FiO2 itself is higher, even if their SATs are at 92%, and understanding the physiology of what happens when you wash out all the nitrogen from the gas and it's all oxygen, and seeing what happens, you're fighting yourself on the alveoli recruitment front, right? You're actually potentially inducing less open alveoli for gas to exchange. And when I kind of came around to that, I'm like, yeah, I really should be more conscious about this. Even if the PaO2 is not like 4 billion, maybe I should focus on trying to get it a little bit lower. Now we have our initial settings in. I always tell people it's not like one of those Ronco rotisseries where you can set this thing and forget it, right? And it's not just making adjustments based on the saturation if their SAT drops to like 70%. What's your first move? One of the most important things that you check to make sure we're actually protecting these people's lungs?
Absolutely. And this is one of the big things. Everything we've talked to so far has just been the basic settings, right? So we're talking about that tidal volume of 6 cc's per kilo, that rate of 16 to 18, that PEEP of 8 plus based on your ARDS table, and then getting your FiO2 less than 60. But just because you do all of these things doesn't mean you're actually achieving lung protective ventilation, right? There's a couple other pieces we still haven't talked about. And that goes into this optimization piece because each patient is different. I can follow the cookbook vent settings, and for some patients that's great, but for other patients that's not achieving what I want it to. So the first thing that I look at to decide are my initial settings actually protecting their lungs is that plateau pressure. And the reason being that's just got the most evidence behind it, right? So really making sure my plateau pressure is less than 30. Brief caveat, how do you get this number, right? The problem with the Hamilton ventilators, they have continuous flow dynamics. Basically what this means is you can't do an inspiratory hold to determine what your plateau pressure is like you would on an ICU ventilator. The nice thing is the Hamilton T1 itself has a couple ways you could figure out what your plateau pressure is. Depending on the software version you have and monitoring tab 3, it actually will just give you a plateau pressure, which is really nice. The other option is it calculates a C-stat for you, which is your lung compliance. And you can take your tidal volume divided by your C-stat and add that number to your PEEP, and that'll get you your plateau pressure. So those are the two ways to actually find that number, right? So you found your plateau pressure on your Hamilton, and you look at it and you're like, man, my plateau pressure is 33. I'm just not where I'm supposed to be. I'm not less than 30. Now what do I do, right? So what's next? The first thing that I do is look at the patient. So making sure they're adequately sedated, making sure they're not coughing, they're not breathing, 8, 10 times over the rate that you set, and making sure they're nicely sedated is huge, especially early. Looking for kind of deeper sedation can be really helpful in your vent management. So don't be afraid to take your sedative agents up. Sometimes that means you'll need to add a little vasopressor, but that's okay. The vasopressor is not going to be the end all be all for them. The next thing I check for, and what we kind of talked on earlier, is making sure all of that volume I'm putting into their lungs, they're breathing out. They're not having that volume accumulate in their lungs and therefore add increased pressure to their lungs. So that's that auto PEEP or that breath stacking that I'm looking for. There's, again, a couple ways you can check for this. Again, on monitoring tab 3 on the Hamilton, there's this little auto PEEP that just calculates it for you, which is super slick. Anything more than 3 to 5, I worry about and think about as being clinically significant. And then the other piece you can look at is the flow waveform and making sure the expiratory flow comes all the way back to baseline, meaning they're getting all of that volume out of their lungs. Those are kind of the next two pieces that I'm checking. And once I've done those two, the next thing I do is I peek at their belly. Were they being bagged by EMS for a long time before they got intubated? Were they on BiPAP? Is their belly just like huge and distended and full of the like Coke and 3 sandwiches they ate before they came in with their ARDS? And if your belly is big and distended and squishing your lungs, that's not helping you either. So thinking about dropping an OG, getting them decompressed. And then once I've done all of those things, I've made sure they're sedated, I've made sure there's not air accumulating in their lungs, I've felt their belly, then you just take your tidal volume down. Maybe they need less than 6 cc's per kilo, and then recheck after that.
Nice. And how much are you coming down on the tidal volume at a time? You feel like you've taken care of everything else. You're like, oh man, their lungs are super stiff. Their compliance is terrible. Let's come down on their volume a little bit. How much are you coming down?
Usually by 1 ml per kilo, assuming they're not super acidotic yet. So a little bit of that is going to depend on your patient too, but typically by 1 at a time.
Let's say you come down by 1. I'm actually kind of a little bit more of a weenie. I'm a little more, I'll come down by like 0.5 at a time, which sometimes is like 30 cc's, like a syringe of air. But I'll come down a little bit smaller. Do you immediately compensate for that loss of tidal volume by going up on the rate? Do you check a gas? What's your approach?
Honestly, it depends when their last gas was, right? So if I have a recent gas, the step I'm backing up a lot, what I look at is my minute ventilation, right? Your minute ventilation is the number that includes both your rate and your tidal volume and tells you exactly how much air you're getting out of the lungs to clear CO2. So I look at that before I make any changes to my tidal volume or my respiratory rate. And let's say my minute ventilation is 12. Then I take my tidal volume down and I see how much my minute ventilation changes. If it only goes down to like 11 or 10, and their pH before I did that was like 7.35, it was fine, I might not make any change to their rate. They're probably going to tolerate that decreased minute ventilation just fine. However, if their pH is already right at like 7.2, 7.21, and I'm dropping their minute ventilation by more than like, 2 to 3, I'm probably going to take the rate up a little bit to try and get a little closer to the minute ventilation I had before I made those settings, just to try and prevent them from becoming really acidotic.
Cool. And I think Brittney made a really important point here that looking at the minute ventilation, and I would encourage all the crews, especially in the transport environment. In the ICU, we have point of care blood gases, and everybody's got an A-line, and I can just send Q5 minute gases if you want to. It's really not a big deal, and we have plenty of help to do that, right? But I think paying attention to the minute volume, the last time you got a gas, or asking what the settings were when they got that gas, what was their minute ventilation, can be really helpful, because then you don't necessarily have to get a gas as long as their parameters are reasonably close. You can just say, oh wow, like we dropped their minute ventilation quite a bit. Let's go up on their rate a little bit. And because of the relationship between CO2 and minute ventilation, both mathematically and I think in practice clinically, we can see you can do that. And that I think obviates sometimes the need for us to get gas, especially if you're really trying to move a patient in the retrieval environment. Yes, having an ISTAT, having an EPIC is great, but Q5 minute gases, I really wouldn't do that in the ICU anyway, but getting frequent gases when you're trying to get on the move and you're constantly trying to get to the destination facility can save you time. So, all right. So we talked about changes to the tidal line. We talked about changes to the rate. Let's talk about one of my favorite things most recently, which is changing the PEEP or titrating the PEEP and this cool new concept of driving pressure.
Yeah, so it's no longer that cool of a new concept. This is kind of the new thing. And I honestly, if not now, in the next year or two, I think this is going to be standard of care for ARDS. The volume of evidence coming out looking at driving pressure. is huge. The initial Amato trial was back in 2015. That's like 10 years ago now, man. At this point, so let's back up 3 steps. What is driving pressure, right? What is this fancy thing we keep talking about? So your driving pressure is the difference between your PEEP and your plateau pressure. So it's basically the additional pressure you're giving to the lung that's getting that tidal volume in there. And again, we think that pressure is probably more important than the plateau pressure. And that's what some of the initial evidence has shown. That if you have a driving pressure, 15 is kind of the cutoff that most people are going with nowadays. So if you have a driving pressure that's more than 15, even if your plateau pressure is less than 30, patients did worse. They had a higher mortality. And similarly, if you have a plateau pressure that's less than 30, but your driving pressure is more than 15, those patients also did worse and had a worse mortality. So this is really kind of the new up and coming thing that a lot of us in critical care are following now. All right, so our plateau pressure is less than 30. I look at my driving pressure and I'm like, oh man, my driving pressure is more than 15. And again, that's that monitoring tab 3 on the Hamilton. That's where all the goodness lives. It'll automatically give you a driving pressure, the delta P on that page. If you don't have the newer software that lets you do that, you just take your tidal volume divided by your C-stat, which is also on monitoring tab 3, and that gives you your driving pressure right there. So once you've got it more than 15, man, how do I do? Honestly, it's all the exact same stuff we just talked about for the plateau pressure. There's no kind of magic difference. So you go back, you decide, hey, do I need to sedate them? Is their belly full? Do I need to decrease their tidal volume down? All right, so you've done all of those things. Your tidal volume's as low as you can get it to be because now their pH is 7.2 and their driving pressure is still high. So that is when this PEEP thing comes into play. And honestly, I think more of us are probably starting to play with the PEEP even before touching that tidal volume because PEEP can make a really big difference in driving pressure.
I think that's a really important concept, and I really wanna emphasize that before you go through the how you actually do it. Is because I used to think that a lot of the driving pressure, I'm like, oh, this person has such stiff lungs, like their compliance is terrible. Like, how can going up on the PEEP actually help? And I really want to emphasize what Brittney said, which is that we may be doing it before we go down on the tidal volume because increasing the PEEP, I'm surprised sometimes at how the driving pressure can go down. And I'm not sure if that was where you were going next, Brittney, but I just really wanted to foot stop that one for the audience.
Absolutely. So just like Mike said, if you increase your PEEP, and increasing your PEEP now opens up more alveoli, I now have a bigger lung space that I'm putting that volume into. And if I have a bigger lung space that I'm putting the volume into, I need less pressure. So increasing your PEEP means potentially more lung space available, means less pressure, less driving pressure I have to deliver to the lung. And then I don't have to take my tidal volume down. It's great. However, that's not true for all patients, right? Some patients, you increase the PEEP and their lung is just so stiff or so collapsed. It's like, nope, I'm not going to give you any more space. We're stuck. So that's what I use to try and decide if my PEEP titration is helpful. So I'll take my PEEP up, usually by 2, sometimes more, depending on how sick they are. And then I look to see what happens to their driving pressure. So if I take my PEEP up by 2 and their driving pressure stays the same or even decreases, that PEEP has been helpful. That PEEP has helped open up new lung. Whereas if I take my PEEP up by 2 and then my driving pressure increases, man, I'm not really recruiting or opening up new lung, and that PEEP's really not helping me. The one thing that's a little tricky in the transport setting is PEEP changes. You don't see these right away. This takes like hours typically to see. So I will sometimes cheat and do a little bit of recruitment maneuvers when I change the PEEP to try and kind of pop open more alveoli a little bit quicker and see what that PEEP change does. That's a whole nother talk about how to do those and how they're safe. But just knowing in the transport environment, you're not going to see this change right away. So realistically, as long as your driving pressure doesn't get worse with your PEEP increase, I would keep taking it up.
All right. Similarly, I would say that, sometimes I think we see the increase on the earlier side, like 10, 15, 20 minutes. But I agree, sometimes it does take a while, many breaths over time, and sometimes doing other things like proning them and whatnot before you really start to see any sort of benefit to increasing the PEEP. But it's absolutely worthwhile trialing. That may allow you to manage their ventilation without increasing their rate and without even touching their tidal volume. If you actually pop some of those more alveoli open, you recruit more lung that is participating in gas exchange. Now, I want to sort of wrap up here with a couple of things. And first, and I'll be honest, I was relatively ignorant. I was aware of the concept, but I probably fail at optimizing this. Let's talk about mean airway pressure. And if all those other things, you really can't budge on the PEEP, you can't do some of these other things to optimize oxygenation for this patient when they're refractory. Can you talk about the concept of mean airway pressure and optimal inspiratory time?
Yeah. So who knew the lungs had a map, a mean airway pressure, right? So what the mean airway pressure is it's just an equation. It's your inspiratory pressure times your inspiratory time plus your expiratory pressure times your expiratory time divided by total time. So it is literally the average pressure that the lungs are seeing over a breath. Cool? All right, so why does that matter? There's some decent evidence saying that the average pressure your lungs are seeing over each breath, that MAP or mean airway pressure of the lungs, is actually the pressure that helps recruit and pop open alveoli. Again, similar to PEEP, it's going to take a while for this to work, but it is one tool you can use to help open up lung and improve your oxygenation. Okay, so how do we fix it? How do we make our mean airway pressure go up? Because your inspiratory pressure is typically so much higher than your PEEP, increasing the time you're at that inspiratory pressure is going to give the biggest bang for your buck for increasing that mean airway pressure. So that's increasing your I time, right? And then the next big question I get is like, okay, well, like how high can I increase my I time? If I increase my I time a ton, then what? So how I titrate this is I use my flow waveform. I think a lot of people are used to using the flow waveform, how we briefly touched on earlier, making sure when the patient's breathing out, the flow is going to zero, right? Making sure they're getting all of that air out before the next breath comes. When I'm using it in my hypoxic patients, I'm looking at the inspiratory side of my flow waveform. So again, making sure that flow waveform on the inspiratory side is going all the way to zero before the next breath. So basically what this means is I'm giving the patient the tidal volume that I've set. And once that tidal volume is reached, the vent stops delivering that inspiratory pressure and switches to expiration. And I want that switch to happen as late as possible. I want to take as much time as possible to get that breath in before we switch to expiration. So I want that breath to be finishing right as my flow is getting to zero, right as that flow is coming all the way back down. So that's what I titrate my inspiratory time to. Now, let's say you get a flow coming all the way down to zero, and then you sit at zero for a while before you flip into expiration, right? I'm basically doing a little inspiratory hold on the end of your breath. Okay, well, that's going to make my mean airway pressure higher, right? If I just keep them at that higher pressure longer, even if I'm not delivering more volume at that higher pressure. The problem with doing this is they've never showed that to actually help with recruitment or anything else from a kind of oxygenation standpoint. And like we touched on earlier, the longer time you spend in inspiration, the less time you have to breathe out. So it increases your risk of air trapping and air being stuck in your lungs. So trying to pick an I time that gets that flow waveform back to zero is going to be what you're shooting for.
Nice. I think that's a really helpful way to think about it. I think the other possible side benefit, and this is a great, I think, transition into a topic that I really want to run by you, is if you think about it, when we deliver a breath and mechanical ventilation, not all of the alveoli just pop open, snap open, and that's perhaps bad, right? So the time to gently open up those alveoli, theoretically, and I think there's some interesting physiological data on this, although nothing prospective that shows definitively that this is going to improve outcomes, is potentially increasing the eye time, slowing down on that flow, giving a more gentle breath, if you will, may cause less stress and strain on the individual lung units and may be helpful from a different perspective as well. So when I was thinking about this, as Brittney's probably anticipating me saying, it initially made me be like, oh, well, why was I not thinking really about inspiratory time or optimizing some of these things? And it made me think of the concept of mechanical power. It is maybe going up on the night time and help with the map, but it may also help with delivering a gentle breath and less energy to the lung. And from a lung protective standpoint, Brittney, would you mind enlightening us on what is this newer concept of mechanical power, and are you using it in transport to adjust some of your ventilatory parameters?
All right, I'm going to caveat this discussion with, I am not a math wizard, so I am not sitting here on transport actively calculating this. There's a million things that go through. But I use the concept of what mechanical power is when I'm managing the ventilator in transport. And kind of like I touched on earlier, it's really helpful for me to frame this how we think about something like an aortic dissection, right? So it's about how often we're hitting the lung with that pressure, how much pressure we're giving to the lung, and just like you touched on, how fast we're giving it to the lung, right? If I'm trying to blow up a balloon really fast and snapping it open, that's going to cause more force to be transmitted to the lung than a nice, slow, gradual inflation of the lung. So those are sort of the key points that I think about in transport, making sure I'm not giving too much pressure, I'm not giving it more frequently than I have to, and I'm giving it as slow and gently as I possibly can. Those are the three things I'm looking at. Yeah,
absolutely. It's something more and more I've been thinking about. And I guess the way I conceptualize it is this really ready for prime time? Do we have good RCTs that show that should we be making this in protocols and metrics and QA metrics? Probably not ready for prime time yet, but some very interesting physiological plausibility and some very interesting retrospective data that shows that it's not just the size of the breath and the static single value of the plateau pressure, but probably how many times and how fast when you give the breath you are. And potentially thinking about it, and the way at least I'm conceptualizing it and using it now, is doing the minimum harm. In other words, if their pH is really 7.4 at a rate of 30, do I really need to be ventilating them that fast? Can I actually dial it back and tolerate probably a rate of 24 or 22 and a pH of 7.3 is totally fine. And so I think that's how I'm thinking about it now. So that was awesome. So just to review real quick some of the pearls and high points of the discussion, we went over some of the basic settings, and I know a lot of you are familiar with that, but I wanted to also make sure we were pretty clear on where those numbers come from and why they're important. And also perhaps really thinking about, and also why it's important to do them early on in transport, but thinking about setting it, checking it, and changing it. Set it, check it, change it. The checks being, Brittney talked about, making sure that plateau pressure is less than 30. If it's not, looking at the patient compliance and how, if they're bucking the vent, over breathing, have a full belly of air, not appropriately analgesed or sedated. Also, and if not, coming down on the tidal volume, thinking about the driving pressure and titrating the PEEP. Optimizing the PEEP if it's not optimal, the driving pressure is still high, potentially coming down still a little bit on the tidal volume, and then talking about the rate and how we use the rate to control things. Finally, the optimal mean airway pressure and eye time to provide the best oxygenation with potentially, hypothetically, the least amount of damage to the lung. So remember this is a very dynamic process, and throughout the flight, making sure that we're within these reasonable parameters, and definitely making sure our plateau pressure is less than 30 and changing it to help our patients out as best we can. Brittney, any last words?
No, I think you covered it. That is like my new favorite phrase I'm going to be preaching to my team. Set it, check it, and change it. This is not set it and forget it. We're better than that.
Yeah, I feel like I should be doing an infomercial for the ARDS net or something like that. Well, everybody, thank you so much for joining us. Take care, stay safe, and do good things for your patients out there. We'll talk to you on the next episode. For now, bye-bye.
This has been a production of the Flight Bridge Ed Podcast, leading the way in pre-hospital critical care and emergency medicine education.